Music and Pain, a Quantitative Analysis by Michelle and Janelle. Will a single music therapy session reduce pain in palliative care patients? This is the question from the study, Music Therapy Reduces Pain in Palliative Care Patients, a randomized control trial by Gutzel et al. To answer this question, the researchers used an experimental study with a pre-test, post-test control group design. They used a purposive sampling method in order to ensure the participants met the specific criteria. Participants were recruited between September 2009 and August 2011 from the University Hospital's Case Medical Center in Cleveland, Ohio. They were referred to the study by the nursing services and the palliative care team. Researchers then reviewed their chart and interviewed them to see if they met the necessary criteria. 5 inclusion criteria included: the patients must have a diagnosis of advanced, potentially life-limiting illness, they must be at least 18 years of age, their pain must be at least rated a 3 on the numeric rating scale, must be able to understand English, and they must be aware of person and place, be alert, and be able to rate their pain on a numeric rating scale. Consent forms were signed and the Hospital Institutional Review Board approved the study. Using this criteria, 200 participants were selected for the study, with 100 participants in each group. The clinical nurse specialist, or CNS, assessed the patient's pain using 3 different measures, then left the hospital to blind them from the study. All participants were then made comfortable with blankets, dimmed lights, and no noise distractions. The music therapy group was then led by a music therapist through muscle relaxation, breath awareness, and invited to use mental imagery to create a safe space in their mind. Harp music was then played using the same songs for every participant in that group. The participant was gently invited to leave their safe place after the music and come back to the present, being reminded that they can return to that place anytime they need. The CNS then was called back to the hospital to do the post-test assessments using the same 3 measures within 10 minutes of the intervention.
There were 3 outcome measures used in this study, and the article didn't go over information on reliability or validity, so we did look into it ourselves just to get a better idea. The primary measure used was the numeric rating scale, which is a rating of intensity of pain. It does have a high test-retest reliability to measure pain intensity, and the construct validity was found to have high correlation with chronic pain. One of the secondary measures were the face, legs, activity, cry, consolability scale, which is a behavioral pain scale that's rated by an observer, and it's used with children or adults that are unable to self-report pain. It has high inter-rater reliability, criterion validity, and construct validity. The other secondary measure used was the functional pain scale. It measures a patient's subjective perception of pain and its impacts on their level of functioning, and it's been found to have high inter-rater reliability and high validity correlations.
The study had a large sample size and a statistical power of 0.80, which makes it more likely to find a statistically significant difference. Comparison of baseline values were made using 2-sided independent sample t-tests with a significance level of 0.05. Since the pain duration variable had a skewed distribution, they used a non-parametric Wilcoxon rank sum to compare the 2 groups. Both groups had a reduced pain with the numeric rating scale with a 95% confidence interval, but the music therapy group had a greater change with p less than 0.0001. The face-leg activity cry and consolability scale did not show a significant difference between the 2 groups, but the functional pain scale found a significant reduction in pain with p less than 0.0001, while there was no difference in the control group. They also did 2-way variance analysis to see if personal differences affected the results and stratified by level based on factors such as ethnicity, age, gender, and diagnosis. The results were not significant for the numeric rating scale or for the functional pain scale, but they found that music therapy had a greater effect on the face, leg activity, cry consolability scores in participants under 55 years compared to those over 55 years. Overall, music therapy had a significant effect on lowering pain in the palliative care patients.
There were several strengths in the study that we wanted to highlight. One was that the researchers used a randomized control trial. The randomized controlled trials are strong designs that could yield high levels of evidence and strong results, which allows for more implication of generalizability. Another was that among the participants, researchers, the music therapists, and the CNS, there was no conflict of interest found. Another strength was related to the assessments. Since pain is very subjective, only using one scale may not allow a client to convey the level of their pain symptoms. But by using three that are highly reliable and valid, the chances of accurately reporting pain, seeing the changes in the pre-post test results, and having stronger correlations in the results increased even more than if they were just using one. Lastly, the study had a large sample size of 200 participants, and to us we thought that was a very great number, which will be stronger in generalizability compared to the previous literature that they had mentioned in the article, in which they had smaller sample sizes. We did find it interesting though because the researchers actually found their sample size to be a weakness. They were referred about 400 patients, but only 200 were willing to participate. So even though that was a large number to the researchers, only having half of the patients wanting to participate, then that may imply that half the population would not be willing to do music therapy in general. But we believe that 200 participants is still a high sample size and that allows for significant results related to what they were intending to study. The other weaknesses were the risks of implicit bias. There was an inability to blind the patient and the music therapist because music therapy requires a music therapist. Both the patient and the therapist were not blinded to the group assignment. There was also inability to blind the patient to the outcome assessment. And when participants cannot be blinded to the outcome assessment, there is opportunity for bias when they're asked to report their subjective levels of pain. The researchers suggested several ways to further research this topic, as seen here, all of which can increase generalizability or increase evidence of music therapy and pain. And we thought all those were great suggestions, but also came up with ideas with occupational therapy specifically, such as having an OT session after music therapy. The study can be redone with the same pre and post tests, but have an OT session after the music therapy session and with the control group to see if music therapy affects engagement and participation in OT sessions in clients that are limited due to pain. And this can also be done as a crossover study design with the control group later receiving music therapy and vice versa to increase the strength in the results.
Using a holistic approach to client care creates more meaningful interventions. With the biopsychosocial model, we can include factors which influence the client's occupational performance and participation. Music therapy can take the client's mind off the pain or impairment and teaches them mindfulness. This study showed relief of painful symptoms, thereby promoting a higher quality of life and well-being. Combined with occupational therapy, it can help clients re-engage in meaningful occupations. For example, Grace Fisher, who at 17 was paralyzed below the neck, used music and art as part of her occupational therapy intervention to overcome her impairments. Using a mouth stick, Grace now participates in meaningful occupations of painting and composing music.
As we can see from what Michelle mentioned in the biopsychosocial model and the study she found, music therapy can address clients' occupations. OTs can even suggest music therapy through interprofessional collaboration, and the OT can suggest music therapy for a client, especially if music is something that they're very interested and very involved in. A lot of research we came across on music therapy included an interdisciplinary team, some of which included the OT specifically. And pain can be a very limiting factor in participating and engagement in occupations. So knowing that music therapy can reduce pain, clients can benefit from it if it allows them to perform their occupations. And with that, similar to the further research we suggested, it can also possibly be used before OT sessions if pain is what's limiting them, and it could even be used at other times in the day so that they can participate in their necessary occupations. I think that the study was performed well. It had a large sample size, clear methods, the results were in line with other supporting literature of music therapy, and the results did show a significant difference in pain levels. I would like to see more research implementing some of the further research suggestions, but personally, I think that even without that further research being done right now, the results and implications of this study are strong enough to have music therapy to be integrated in clinical practice.
I agree and feel the study shows the potential benefits of music therapy interventions. The researchers maintained a consistent approach to each participant using the same prompts and songs, which helps standardize the results. Though music therapy is often individualized, the study's method helps generalize the results to a greater population.